We are live.
Good evening, everyone, and I extend a warm welcome for everyone at iFocus Online. And today is our fourth episode in the series on cataract. And with great pleasure, I welcome Dr. Pavani Murthy, who is a consultant at Center for Sight Hyderabad, and she will be the speaker for this session. The topic for today's session is biometry and intraocular lens power calculation in an uncomplicated cataract. So a brief introduction about Dr. Pavani. She's a consultant in cornea, cataract, refractive and ocular surface at Center for Sight Hyderabad. She has completed her MBBS from Guntur Medical College, Andhra Pradesh, and DNB from Shankara Eye Foundation, Guntur. Research fellowship in cornea from the Shankara Nethralaya, Chennai, and a clinical fellowship in cornea, refractive and ocular surface from Shankara Nethralaya, Chennai. She has over 20 presentations at national and international conferences and has authored 5 peer-reviewed articles in national and international journals. She has previously worked as a consultant in ophthalmology at cornea, cataract and refractive specialty at Win Vision Hospital, Sri Nethralaya Eye Hospital. So over to you, Dr. Pavni. This is a very, very important topic for both the postgraduates as well as for anybody who is practicing ophthalmology. And I think all ophthalmologists at some point will have to do cataract surgery. So over to you, Dr. Pavni, for your talk on biometry.
Good evening, everybody. I'll start my share screen. I hope I'm visible. Thank you, Dr. Jayata ma'am, for the kind introduction, and thank you to the iFocus organizing committee for making me a part of this prestigious iFocus platform. Good evening, one and all. I'm Dr. Pavni, and without further delay, I will be starting our topic for today, which is on biometry and intraocular lens power calculation in uncomplicated cataract. So what is biometry? Biometry is the art of applying mathematics to biology. It all started during World War II when Sir Harold Ridley, one second please, I lost my, when Sir Harold Ridley saw Air Force casualties with eye injuries, including a squadron leader, Cleaver, he observed that when the splinters of the acrylic plastic from the aircraft cockpit canopies became lodged in their eyes, this did not trigger any inflammatory rejection as did glass splinters. This led him to propose to the use of artificial lenses to treat cataract. He had a lens manufactured using the same material by Rayner, which on 8th February 1950, he implanted the first artificial lens. Post-operatively, he was left with a refractive error of approximately minus 21 diopters. So later on, Binkhorst introduced a 18 diopter prepupillary lens, but it left the patient with the same refractive error which he had previously before the cataract surgery. So the IOL formulae calculation was born. Fyodorov was the first person to utilize a formula for the prediction of the correct IOL power. Nowadays, cataract surgery is no longer a simple cataract extraction. It has become a refractive cataract procedure aimed at achieving optimal unaided vision. So what is characterized as success? It is not just a safe and efficient surgery, but getting a near perfect refractive outcome aimed at giving spectacle independency to the patients. The most common cause of dissatisfied patients is because of the residual refractive error which is being left behind. So kindly remember that do not overpromise and underdeliver, but set the expectations right. It is important to know that a higher power IOL that is only 0.1 millimeter forward in the capsular bag can cause a 1 diopter refractive error. Thus, the importance of meticulous examination and calculations. So, how do we overcome this? This we can divide into 3 categories: preoperative, operative, and postoperative. In preoperatively, try to give adequate chair time to the patients ask about their occupation, daily activities, hobbies, set the patient expectations right, do a meticulous pre-op evaluation. Nowadays, it is very important that you ask for history of laser vision correction. Do a dry eye evaluation. If needed, do an OCT macula. Do give proper counseling to the patient. Do biometric measurements and choose the right IOL which is best suited for the patient, and then calculate the IOL power. Intraoperatively, a precise surgery within the back placement of IOL is a necessity nowadays. In scenarios such as PCR or zonular dehiscence, where a normal IOL cannot be placed in the back, or you want to place it with certain optic captures or give it scleral fixation, sulcus fixation, kindly modify the IOL power according to your place of implantation. So there is a rule of thumb for sulcus placement of IOL. This is taken from the back sulcus algorithm from Dr. Hill, which almost everybody nowadays follows. In cases where the zonular support or the back support is not good and you're planning to change the IOL design, like an AC IOL or iris claw lens or a scleral fixated IOL, calculate the IOL power accordingly using the correct A constants. Post-operatively, do a correct refraction to find out the residual number, if any. Make sure that you examine the patient on slit lamp to find whether the IOL is centered exactly in the bag, is well centered, covered by the rhexis margin all throughout. If it is a toric IOL, whether the axis of the IOL is rotated as the axis you had planned. A word about ocular surface optimization preoperatively. It is important to note that patients who are suffering from dry eyes have symptoms very similar to cataract. They can present with nighttime glare, halos, decreased visions, etc., and can be easily confused with having symptoms being attributed only to cataract. It is important to know that whatever tests you do will be full of errors, like the refraction, keratometry, topography, aberrometry. Everything will have its own margin of error. Not just that, after doing the surgery, the chances of infection drastically increase. The surgery itself is going to worsen the dry eye, which the patient is going to attribute it to the surgery itself, and leading to a dissatisfied patient as well as a dissatisfied doctor. What we have to remember is that in the incidence of dry eye, there could be two categories, symptomatic and asymptomatic. What we should aim for is to find the patients who are in this asymptomatic category and to give treatment preoperatively before taking these patients for surgery. Maybe giving dry eye questionnaires for during preoperative evaluation for cataract patients might be one of the ways to go forward. In addition to that, look for the lids, look at the ocular surface, do fluorescein stain to find out if there is any dryness, lift the lids, look under the lids for any allergic reactions to see for, pull the lids to look for laxity of the lids, then push so that you can make out the secretions or inspissated mucus which is present in the meibomian glands. The topography Myers could be regular or irregular. The irregular would point towards an altered ocular surface, and meibomian gland imaging is a very nice tool where it can be used for patient education as well. You can show them gland dropout areas like in this picture where the entire glands have dropped out, or you can also tell them about the gland increase in gland tortuosity and the glands being dilated, which is contributing to their dry eyes. You could also do TFL osmolarity or MMP9 measurements if you have access to. The goal over here for treatment is basically to reduce the surgical delay time. So follow a multifaceted approach, give hot compresses to the patients, explain how the lid margins are to be treated, give anti-inflammatory medications, oral tetracyclines if needed in cases of systemic conditions or ocular rosacea. You can use LipiFlow IPL to give immediate benefit from the dry eyes, give omega-3 fatty supplements, and also certain cases might require adjunctive treatments in the form of punctal cautery, plugs, autologous serum, etc. So IOL power calculation, the prerequisites are a good axial length measurement, central corneal power, and AC depth. In addition to that, lens thickness, effective lens position, white to white corneal thickness will add up to increase the accuracy of your measurements. So there was a study which was published in JCRS 2008, which evaluated the percentage contribution of the parameters to IOL prediction errors. What you will see here is effective lens position contributed the most, followed by axial length and keratometry contributing to a third of the patients, and post-operative refraction also contributed to a third of the patient. This happens because the standard deviation of the subjective refraction is high, indicating a wide variety in the measurement of refractive outcomes. Most surgeons achieve their target refractive error within plus minus 0.25 diopters in around 76 to 80% of their cases. Around only less than 1% of doctors will be able to achieve it for more than 92% of their cases. But with the advent of newer methods, newer technology, newer IOL formulae, almost most surgeons are able to achieve this target in 90% of their cases. So the effort over here basically lies in biometry, good biometry, IOL selection, and the surgical technique. A few important aspects of cataract surgery to note here are that a 0.1 mm error in the eye of an average length will result in almost 0.25 diopter error in post-operative refractive error. So 1 mm change in the axial length can cause almost a 2.5 to 3 diopters of error. The cornea, change in the corneal diopter by 1 diopter can lead to an IOL prediction errors by again 1 diopter. So the normal average axial length ranges from approximately 22 to 24.5 millimeters. Longer eyes are more forgiving. That means that an eye with an axial length of approximately 30 millimeter, for an error of 1 mm in the axial length, the post-operative refractive error will be somewhere around 1.75. But for a smaller eye, the same error can lead to a refractive outcome of post-operative error of approximately 3.75 diopters. So always remember that you have to obtain data from both the eyes. The difference between the axial length of the two eyes should not be greater than 0.3 mm unless there are relevant ocular findings such as previous scleral buckling or anisometropia or corneal transplant. Sometimes you can have keratoconus or previous refractive surgeries. So coming to types of biometers, these can be broadly divided into ultrasound and optical. Ultrasound, we have contact and immersion. Optical are further divided depending on the technology which they use. The ultrasound biometer is based on the principle that there is a piezoelectric crystal embedded in the probe of the probe, which generates a high frequency sound energy, which penetrates the eye and is reflected from the ocular tissues. The reflected waves are again captured by the probe and converted into a one-dimensional amplitude representation. Most of these ultrasound machines use a frequency of 10 megahertz. And what we measure is the distance from the anterior corneal surface to the ILM. In ultrasound biomicroscopy, the contact biomicroscopy involves you have to explain the procedure to the patient, make sure that the patient is seated comfortably. You can also have the patient lying down on the bed, instill a drop of topical anesthetic, fixate with the other eye, then touch the central cornea without indentation. Note the echo spikes. Make sure that the echo spike's leading edge is perpendicular to the baseline, and the gain should always be kept to minimum. This is an example of high quality contact E-scan of a phakic eye, which shows 5 peaks. The first one is of the probe or the probe and the cornea, the anterior lens, posterior lens, retina, and sclera. Such a high quality scan will have 5 high amplitude spikes with a steeply rising retinal spike. This is the steep rise which we are talking about, and a good resolution between the retina and the scleral spikes. The parameters which you can get from here are the axial length measurement, measurement, the AC depth, and the lens thickness. Since the sound velocity differs in different media, it is important to take into consideration the correct mode when you're doing the calculations based on the refractive status of the patient, the phakic mode, pseudophakic mode, or the aphakic mode. The pseudophakic mode per se has PMMA data incorporated in it. So in case the patient has PMMA or silicone acrylic, you are supposed to use a correction factor to get the correct value. A word about silicone oil, because silicone oil has a different sound velocity. It is much lower than the other values of ocular surface structures. There might be difficulty in getting a good retinal spike, as well as sometimes you can, if you use another velocity, you might erroneously get long axial measurements if you do not use the correct sound velocity adjusted measurements. So the gain settings over here depend upon the density of the cataract. The denser the cataract, the more is the absorption of the sound, and therefore you have to increase the gain to get good amplitude scans. Remember that in aphakic eyes, since the lens is missing, they all require very less gain. So what happens when you increase the gain? The spike height increases, the sensitivity of the display screen are maximized, enabling visualization of weaker signals. But the resolution is adversely affected, as in the scan, where the retina and the sclera are seen as a thickened spike with a wide flattened peak. Here you have to reduce the gain until you see a separate retinal and scleral spikes. So when the gain is lowered, the spike amplitude and the display sensitivity are decreased, but this eliminates the weaker signals and improves resolution. So spike height is affected not just by the difference in density as it travels through the eye, but also by the angle of incidence, which is determined by the probe orientation to the visual axis. Like in this scenario where the sound beam is parallel and coaxial to the visual axis, most of the returning echoes travel back to the probe and give you high amplitude spikes. This is an example where the probe is placed obliquely to the visual axis. The returning echoes, few of them are reflected away from the probe, and thus you get a compromised spike over in your maps. When the macular surface is smooth, most of the echoes are again nicely reflected back to the probe, giving you high amplitude spikes. But in scenarios where the macula is convex, like macular edema, PEDs, or if there are reflective membranes like the ERM or irregular surface like CNVM, there could be multiple reflections of echoes, and the signal which is going to the probe might be much lesser, giving you compromised spikes. So make sure that the patient is either in sitting or lying down according to your convenience, and make sure that the patient's head is flat. This is a wrong position. Putting a pillow will make the iris plane not parallel to the floor. So make sure that the head is flat and the iris plane is parallel to the floor. The probe should be perpendicular to the iris plane. This is a wrong position, and this happens when the patient is sitting and the examiner is standing. Corneal beam should be parallel to the visual axis. So fixation can be done with an overhead fixation target, or as is seen over here, or you can use the patient's own hand for fixating with the other eye. Sometimes we can use fixation light of the A-scan probe as well. So hold the probe by the wire and not directly hold the probe, because it causes compression on the cornea. This is an example of compression related scans. If you look at the scans, both the scans have very good amplitude, very nice 100% spikes with good separation between the retina and the scleral spike. But when you notice the axial length over here, AC depth over here is reduced compared to the first scan, whereas the axial length is also similarly reduced compared to the first one. And the values are mentioned over here. This means that the second scan is a compressed scan. A misalignment error can also happen. Perpendicularity to the macular surface is achieved when the retinal spike and the scleral spike are of high amplitude and the retinal spike arises steeply from the baseline. So there should be no sloping, no jags, no humps, no steps over here along the ascending edge of this spike. If you notice a decreased amplitude of the posterior lens spike, this again could point towards misalignment. So here we see that the scleral spike is missing. This means that there is a misalignment along the optic nerve. Coming to immersion scan, here since the probe does not touch the cornea, this removes the indentation error. So you have to ask the patient to lie down supine. Of course, explain the procedure to the patient, make the patient lie down supine, put a drop of topical anesthetic, place a scleral shell, pour it with saline or methylcellulose depending upon the manufacturer's guideline. They make sure that there are no air bubbles which will increase the noise since the probe is immersed and the probe is almost 5 to 10 millimeters away from the cornea. There is no corneal compression. Fixate with the other eye, then align the optical axis and note the echo spikes. An ideal immersion scan has six spikes. The probe and the corneal spikes are now separate since they are not in contact with each other. And the corneal spike has two peaks, which represent the epithelium and the endothelium. When these peaks are not equally high, that means that the probe is not aligned with the visual axis. And if it is not seen as a single two separate spikes, make sure that if the gain is reduced properly to discern both from one from the other. Most of the studies have proven that the eyes measured by immersion method are on an average 0.1 to 0.3 mm longer than the eyes measured by the contact method because there is no indentation of the globe. There are, yes, limitations with the immersion. It is time consuming, it is messy, the patient has to lie supine, the cleaning of the probe and the shell should be done meticulously after each and every scan. Pearls over here are to calibrate the instrument properly, make sure that the immersion or contact method is done in the correct position. Immersion should always be supine, contact can be both supine or in sitting position. The iris plane should be parallel to the floor. Probe should be perpendicular to the iris plane. Patient fixation is important. Hold the probe by the wire during your contact contact scans. Check the waveforms of all the scans. Check the AC depth to avoid inadvertent corneal compression. Take multiple readings with low standard deviations. Delete the erroneous values. Do not average the readings, but choose the best waveforms. So in certain scenarios like posterior stapeloma, do a B scan to find the relationship of the macula to the stapeloma. There might be an inability to display a distinct retinal spike. The deepest position of the stapeloma may be located eccentric to the macula. Thus, the measurement may be longer as compared to the true axial length along the visual axis. Short eyes, as we have seen, carry more inaccuracy for even a single millimeter in error in axial length. Macular lesions, especially elevated macular lesions like tumors or edema or arteries, also may prevent the display of a distinct retinal spike. It also causes shortening of the axial length. Vitreous lesions like asteroid hyalosis and vitreous hemorrhage give additional vitreous echoes. The ultrasound microscopy measures the anatomical axial length. It might or might not coincide with the optical axial length, which in a typical human eye is tilted approximately 5 degrees horizontally and 1 degree vertically relative to the anatomical axis. So long and short eyes on optical biometry might be better. Posterior cerebelloma, optical might be better, and an experienced operator is required for doing an ultrasound biometry, which is negated by the use of optical biometry. In denser cataract, actually, ultrasound biometry is much better compared to the optical biometers. But yes, because we have to use high gain and the dense cataract absorbs the sound, we might not get as good results. Pseudophakia and silicon eye-filled eyes, because the correction factors and everything are needed, are yes limiting factors for this kind of biometry. Corneal indentation, misalignment of the probe, low sound velocity, too high a gain, and macular thickening or RD can cause erroneously short measurements. Air bubble in the fluid bath, rapid sound velocities, too low gain, posterior stapyloma, thickened lenses can cause erroneously long measurements. It is important to know that these scans, ultrasound scanning is up till the ILM, internal limiting membrane only, whereas optical biometers measure until RPE. Therefore, a correction factor is needed. So the A constant for ultrasound biometry is different from the A constant for optical biometry. So if you are using an A scan which is taken from an ultrasound, as in a case of dense cataract, and then using this value to enter in the IOL master, make sure that the ultrasound A scan value is A scan constant is entered for measurements. There are multiple studies which prove that the immersion technique has better repeatability. Having said that, there are few studies also which show that in the hands of experienced optometrists or technician, the precision of contact versus contact is almost equivalent to that of immersion. Coming to optical biometers, there are three different types depending upon the technology which they use: partial coherence interferometry, optical low coherence reflectometry, or swept source OCT. IOL Master 500 is an example of partial coherence interferometry. It measures around 6 points in a hexagonal pattern within an optical zone of 2.3 millimeters. What it measures is, what it gives us is HCl length with accuracy, keratometry with average accuracy, and ACD and white-to-white measurements. LensStar 900 is based on optical low coherence optical reflectometry. It measures around 32 points in two optical zones. It is a placido-based examination. It scans approximately 128 points of measurements in 5 sets, so total 640 readings are captured. IOL Master 700 is a swept source OCT with an added feature called telecentric keratometry, which we'll come to in a bit. It is a 3-zone keratometry which captures almost 2,000 scans per second. It takes continuous V scans from the cornea to the foveal pit, and it gives measurements in addition to the normal parameters in AQD as well, which is the distance between the posterior surface of the cornea to the anterior lens capsule, which is more important in phakic IOLs. Since it is a swept source OCT and gives posterior corneal surface, we can calculate the true K and can thus use the Barrett true K formula also. It has an inbuilt algorithm for silicone oil and patients with laser vision correction. So this is a video by the manufacturers, basically an IOL Master 700. What is telecentric keratometry is that even if the device to eye distance is varied, the spot size does not change much. That means that the measurement is motion independent, independent of the focus. So whatever measurements, even if out of focus if taken, are reliable enough. In contrast to non-telecentric biometers, where the focus you have to focus correctly to take measurements. The anterior corneal axis can be considerably different to the posterior corneal axis, resulting in different corneal astigmatism. Resulting in different total corneal astigmatism. So IOL Master 700 measures posterior corneal surface. Few of the formulas, like the Barrett Universal Truth, use nomograms to interpolate data to form posterior corneal astigmatism. The true K calculated here can be used in almost all the formulas like the Hopper, Holiday, Haigis, SRKT, except in Barrett, which has already a nomogram built in it to extrapolate the posterior corneal surface. Of course, with this instrument come the Barrett suite, which take into consideration the 2K values. This is a snapshot of the image which you see. There is an anterior keratometry, posterior keratometry, and also total keratometry data, which you can see over here. You can check and confirm the axis and cylinder with at all the levels. So this is the B-scan which we were talking about. It takes continuous B-scan measurements, and whenever the foveal pit is visualized, that is the time when you have to take the measurements. So this is a added feature of IOL Master 700. It is fixation. It is called fixation check. Basically, this video is going to show. I think I don't have control over the video, but basically it is going to take 2 measurements. Yeah, this is the first measurement where the foveal pit is not visible. Again, it is going to take another measurement where again the foveal pit is not visible. And when you look at these axial lengths, there is significant difference in the axial length, leading to significant error in IOL power calculation. Yeah, so this is the difference. So when we repeat these measurements, fixating properly, like in this scenario, again, foveal pit is visible. Similarly, another reading where the foveal pit is visible, the difference between the two scans, axial length, is hardly 10 microns. So hardly significant. This gives nice repeatability. So limitations, yes, optical biometers cannot be used in certain conditions which have significant media opacities like dense cataracts and all where absorption of light, or there might be an inability of the patient to fixate onto the target, limiting the use of optical biometer. If you are asked the question if any biometer is superior to others, in an experienced hand, ultrasound biometers can give you very accurate and repeatable measurements. But optical biometers have the advantage that anybody can use it with accuracy. It is non-contact, less time taking, and sometimes you can give additional information like the posterior corneal power, which will enable increased accuracy in IOL power calculation and also for calculating astigmatism and planning toric IOLs. So we come to the topic of keratometry now, which is the measurement of the curvature of the anterior surface of the cornea along a fixed chord length, usually 2 to 3 millimeters, which lies within the optical spherical zone. So as we'd already seen that less than 1% of the surgeons can achieve around plus minus 0.5 diopters of their target sphero equivalent in more than 90% of their patients. A 1 diopter error in keratometry can lead to almost 0.9 diopter error in IOL power prediction. Keratometry can be done in 4 ways: manual keratometer, autocave, optical biometer, or topography or tomography. Manual keratometer is based on the fact that the anterior surface of the cornea acts as a convex mirror and the size of the image is formed, which is the Purkinje image, varies with the curvature of the cornea. So this formula, I hope you are already aware of how the formula is derived. This is the object, this is the image. The object throws the light through when it passes through the radius, through the center of the optical system. It is reflected back onto itself, but the light rays which form on the Q area are reflected outwards. So if we backtrace it, it will meet the first ray at A dash. So A dash, B dash is your image. So when we place this AB, the object, at infinity, where the parallel rays of light are going to come, the image is going to be formed on the focal length of the surface. So that means the distance of the image divided by the image size is equal to the the u, which is the distance of the object divided by the object size. Since focal length is approximately, since focal length is half of radius of curvature r by 2, I by I is equal to u by 0, and r is derived from this formula. So as it is impossible to immobilize the eye, we use a concept called the visible doubling. So depending upon which area is fixed, which parameters are fixed, this can be based on 2 concepts called the fixed doubling or the variable doubling. Fixed doubling has a fixed object height and doubling device distance. What is variable is image size and the Maya separation. An example is a Bausch and Lomb keratometer. Variable doubling, image size, and the Maya separation is fixed, but the variable parts are the object height and the doubling device distance, like the Hagstreet or Jawal-Shior's keratometer. So when you have 3 variables that are constant or measurable, you will be able to measure the fourth one. As in the case of Bausch and Lomb keratometer, where you have fixed object size, so you can calculate the image size from which you can interpolate the radius of curvature. In the case of Jawal-Shior's keratometer, having a fixed image size, So when we measure the object size, we will be able to get the radius of curvature. This is a ray diagram generally asked in exams. So I'm going to go through the ray diagram of this keratometer. Basically, what happens is light rays from the bulb are reflected by the mirror. Um, yeah, by the mirror, and they form these mires onto the patient's cornea. The image now is going to act as a second object. The light rays from the object pass through the objective lens, the aperture diaphragm, the doubling prisms, then leading to an image. When the light rays pass through the aperture C, they travel through the base up prism and will be deviated up to form the image on the superior mire. The light rays from the aperture D will pass through a base out prism and will be deviated to the right to form this mire. The light rays from the aperture A and B travel in between the two prisms and form the central mire. Now, these mires are being appreciated by the observer's eyes through the microscope, but through the eyepiece. So make sure whenever you're doing manual keratometry, proper alignment is very, very important with proper placement onto the chin rest, the forerest, and then the canthal marker. This is the canthal marker which should be aligned with the canthus. Occlude the non-testing eye, focus the eyepiece which is over here, and then bring the cross into this. When you focus the eyepiece, this is going to become a single circle. Bring the cross into the center mire. Then you have to adjust the horizontal mires to coincide the plus sign, and then you adjust the vertical mires to coincide the minus signs. Then you read the key values which are seen on the tiles up to 3 decimals. In case of oblique astigmatisms, wires will be tilted. And you will not be able to coincide the plus size. You have to tilt, you have to rotate the entire optical system to align these plus signs. And then the axis can be read off from the scale. Limitations of manual keratometry is that it is based on the false assumption that cornea is symmetrically spherical. When we know that the cornea is aspheric and the two principal meridia are at 90 degrees. Only central 3 mm of the cornea is measured, so there is a possibility that you can miss conditions like keratoconus, PMT, etc. Accuracy is lost in very flat to very steep cornea, and it is a one-position instrument which assumes regular astigmatism. That means it cannot calculate irregular astigmatism, even small corneal irregularities like aberrations, erosions, epithelial defects, dry eyes, pterygium, which give rise to irregular astigmatism, cannot be measured. It has an assumed corneal index, thus the values which are got from manual keratometry, you will not be able to compare it with different instruments. And of course, this requires experienced technician to be able to do correct manual keratometry. So inadequate calibration, this is one of the leading causes for errors in keratometry. Inadequate examination techniques, or proper alignment, proper focusing of the eyepiece, and clarity of the mires is very, very important. If you are unable to locate the mire, the instrument or the patient might not be aligned properly. If there is transient mire clarity, that means that there is some dryness. Ask the patient to blink a couple of times. If there is transient mire focus, then probably the forehead is not secured to the headrest. If there is unsteady patient gaze, occlude or patch the other eye, and then you see, try to focus and take keratometry readings again. If only one minus sign is visible, that is the upper part is minus part is not visible, that means probably the eyelid is drooping, and ask the patient to open their eyes wider. Only one plus sign is visible. Most likely the occluder is on the way, so you have to push the occluder away and then recheck. So inadequate fixation, cooperation, all these things, corneal abnormalities, and also the examiner having an uncorrected refractive error results in fluctuating accommodation and abnormal focus. Conditions like post-refractive surgery or corneal transfer, corneal scar, and keratoconus, these are the conditions where it is difficult to get manual keratometry readings. So take-home points, calibrate periodically. If you have measurement to measure inconsistencies, inter-eye difference of more than 1.5 diopters, astigmatism in either eye more than 4, validate it with either another examiner or ask the patient to come back on another day. This test should be done prior to any corneal contact procedure and avoid using anesthetic eye drops. And yes, this is based on examiner's skill set. Coming to AutoK, this works on the principle that the image is reflected of the target and is focused onto the photo detector, which assesses the image size, and hence the radius of curvature is calculated. The advantages are that it is quick, not dependent on the skill of the examiner. That is why inter-observer variation is eliminated. It takes less time, has better patient cooperation, can be used in children, but disadvantages are that the acquisition is static. That means the examiner has no appreciation of the accuracy of the measured movement. Automated keratometries can have two modes, automatic or the manual mode. Automatic is where the AK machine directly on itself focuses and takes the values which have best Myers. But in cases of mature cataract, the fixation is not very good, so you will have to shift to manual mode so that you will be able to take correct measurements. Again, there are two modes over here, RK mode and the keratometry mode. RK mode takes around 3 values and then averages it, but K mode takes more values. It is more accurate. So if you're looking for accuracy, opt for the K mode. Optical biometers also give keratometry values. A word about IOL Master 700, since it gives an additional posterior corneal astigmatism, a true K value can be calculated. Topo and tomography. Topography is a two-dimensional placido-based system for measuring the anterior surface of the cornea. Tomography is three-dimensional elevation-based. Remember that in pentagram sheen plug, there are no Myers. So you cannot make out the ocular surface regularity. Steep K over here can be used for toric IOL calculation, and EKR values of 4.5 are again pretty important, which was again discussed in last class. So role of topo and tomography is more in planning incisions to reduce the pre-existing or induced astigmatism. You can plan your incisions, plan LRIs, clear corneal paired incisions, astigmatic keratotomies, assess the spherical aberrations for choosing spherical IOLs, and assess the posterior corneal astigmatism and measure corneal power. It can be used for refining the axis since it is a placido-based test, and can be used for toric IOL calculation. So it can be used for screening of irregular astigmatism. It is important to know that when you have irregular astigmatism, do not use diffractive optics, as these can worsen the aberrations which are produced because of the irregular cornea. So negative spherical aberration results in better contrast sensitivity and better image quality. So those whose requirement is a better image quality offer negative spherical aberration IOL. The higher the spherical aberration, it leads to higher depth of field. So in such scenarios, neutral or non-aspheric IOLs can be preferred. Post LVC in LVC for hyperopic corrections, the cornea becomes hyperpolate and induces negative spherical aberrations. You should probably go for neutral or non-aspheric IOLs. In myopic corrections, myopic LASIK, the cornea becomes oblate and induces positive spherical aberrations. Here it is good to use negative spherical aberrations. I am not going to go much into details because higher order aberrations, pentagam, Q values, RMS it's in itself is a very large topic. So manual K is the gold standard. Corneal topotomo can be used for screening of irregular corneas. These can be used for planning the size of planning your incision to reduce astigmatism and also for calculating posterior corneal astigmatism. Surgically induced astigmatism for a 2 mm corneal incision, like in MICS nowadays being done, is practically minimal. A word about effective lens position. We have already gone through this slide. Effective lens position contributes almost 35% of your post-operative refractive surprises. So this is a chart which shows that your normal ACL length 22 to 24, if you have a AC depth error of 0.25, you can land up with a post-operative refractive error of minus 0.3 to 4. In a high ACL length of around 30, the error is minimal, 0.1, but if the ACL length is around 20, the error is almost 5 folds. The factors which affect ELP are many, the anatomical, not just the anatomical factors, but the IOL related factors as well, as like the shape, the length of the IOL, the materials with which it is made, the anterior angulation of the haptics, the material of the haptics, and the certain factors like the rex's shape, whether the rex's nicely overlaps the optic or not, the type of the lens which is being used, a PCIOL, a sulcus fixated IOL, or and also on the capsular bag integrity. IOL formulae have been divided, have been classified in various forms. One of the common classification is generation-wise. This is the classification which is commonly followed. Historical or refraction-based, Fyodorov and Binkhorst, we discussed about this in the initial slides, and historical are now obsolete. The regression-based analysis and regression analysis-based like SRK, SRK2 are also obsolete. Most of the IOL masters, most of the A scans, especially the ultrasound A scans, they give SRK2 also in their printouts, so kindly do not follow these. The newer versions formulas are again divided into different varieties depending upon the variables which they use. Universal Barrett 2 is commonly being used now with high accuracy. Artificial intelligence based formulas like Hill, RPF, Gain, Pearl, DGS, EBO are really good. Ray tracing is again the future. Oculix, Phaco optics, but these are paying options. Now, when you come to normal axial length, almost all the formulae give pretty good accuracy. But if you go to longer axial length, many of the earlier formulae use Wong-Cook axial length adjustment to give accurate readings. If you look at the newer formula like the Barrett or the Hill RPF, basically these are really good at not just the normal but also at the short and the long axial length. Barrett Universal 2 is available online for free for newer IOL biometers. It is incorporated into a machine known as the Barrett Suite, but gives 2K as well as toric IOL calculation. The Hill RBF version is an artificial intelligence. This does not depend on the ELP and it gives radius values as out of bounds, so you can remove those extra values. There are many limitations to the existing IOL formulae, and these have been studied over a long period of time. There is a large study which was done on almost 18,500 cases comparing the accuracy of Barrett, Hayes, Holiday, Olsen, SRKT, and they found that the Barrett Universal 2 has lowest prediction error in their study, which included only two models of IOLs. Meta-analysis has shown that newer generation formula like the Kane, Barrett, Olsen, these have very good accuracy in high axial myopic eyes. Similarly, for short and long axial lens, Barrett true axial length, EVO, Pearl, DGS, all these are found to be pretty much accurate. This is a recent publication which came out in 2024, but this is artificial intelligence. It discusses about the artificial intelligence-based formula. This has concluded that Kane is out of the ones which were tested. The list is mentioned here. Kane was seen to be most accurate intelligence-based formula, followed by Pearl DGS. The nutshell is that try to use multiple formulae, preferably newer generation, for more accuracy in all your surgeries. Thank you.
Thank you, Dr. Pavani. That was, I think, covered all aspects of the topic very well. And yeah, so we appreciate that this is a very, extensive topic, and you have really given us a lot of insight about the various aspects of this. So, any questions from any of our participants?
Hello, ma'am.
Yes, go ahead.
Hi, Dr. Ishita.
Hi, ma'am. Good evening. I would like to know about if we have access only to the ultrasound biometry. Is it a reliable instrument for premium IOL calculations?
So nowadays, not everybody has access to optical biometers because of multiple reasons. Maybe you have own a small practice. Maybe you are working in remote areas where your resources are limited. Having said that, if you have a good trained optometrist or a technician who can take very good values of ultrasound, immersion, and contact values, immersion is preferable. These have a high repeatability, high predictability, and accuracy. So you can happily use this for all your premium IOL cases.
We have a question from Dr. Kadimi Hashi, and the question is how to diagnose after cataract surgery that my calculation is not right, and how I calculated if I need to change the IOL. So this question has come via YouTube. So any answers to that, Dr. Pavani?
So after the surgery is done, it depends upon multiple factors now. One, you have to go back to your previous calculations, whether everything is done properly. If a toric IOL was used, whether the toric IOL is aligned properly. The next, post-operatively, yes, you will have to repeat these measurements again. Look whether you have the patient had undergone any kind of a complicated cataract procedure, which can also lead to changes in the post-operative refractive power. Like if let's say the patient had a PCR and the lens was placed in the sulcus without proper correction made to the IOL power, it can also lead to some amount of residual error. The second part of the question was how to calculate, was it?
Yeah, and if I need to change the IOL, if an IOL, exchange has to be done, then how do we calculate the IOL power in case an exchange needs to be done?
First, you have to get correct measurements. So you wait until the cornea is much better, the area's AC is quiet enough to retake your measurements. Then you decide whether you want to change the IOL. Now here, few people are more forgiving. They will be able to get, if let's say you are left with a refractive error of -1, -1.5, people find it much easier to focus onto the near objects. This is basically the mini monovision which we talk about. So you will have to sit and discuss with the patient whether they are comfortable with that or not. If yes, you are left with a refractive error of more than 2, 2.5 or 3, then of course you will have to think about IOL exchange. Go back to your parameters, reconfirm them, probably use another optical biometer to get the correct measurements, and then decide on the IOL power using multiple formulae, not just one, probably a Barrett and new generation formulas like the Hill RBF and EVO, and then you land up at the decision for which whether to explant or to take which IOL number to implant.
Right. So a good way to avoid these situations is, of course, the files must be checked before the surgery, and the IOL should also be checked, and there should be a checklist. And before implanting the IOL, make sure the correct IOL is being put in the correct patient. But sometimes surprises do occur, and I think once in a while, very rarely, you may have to even exchange the IOL and put the correct number. But it can be managed. It's possible to correct it also.
So I think it is very important to make it a point that you identify the patient preoperatively on the day, preoperatively as well as when you're doing the surgery by their name, by their initial, then the eye to be operated, check the file, check whether the IOL is the same as what you have ordered, the A constant matches, and the type of the IOL is correct, that which you have selected.
Right. Any thoughts on Anterion? Because do you have access to Anterion, or have you used it for any IOL power calculations?
Ma'am, so actually I have not used Anterion, but yes, from the discussions which are going on, it seems to be very good at calculating almost all the parameters. So
Right.
I do not have experience in that.
So we really, I think we need to compare between the IOL master. Most of us are using IOL masters, I think, in most of our practices. So maybe we'll have to see how the IOL powers, compared when calculated on both the machines.
Yeah, yeah.
So any other comments or questions from any of our participants?
Yes, ma'am. Good evening, ma'am.
Yes.
Ma'am, I want to ask you that in case we have only access to we don't have access to optical biometers. How will we, like, is it difficult to calculate the toric, calculations specifically for a toric IOL?
For implanting a toric IOL, I think with the advent of premium IOLs, especially multifocal, EDOF, and all these lenses, that we are giving the option of these lenses to the patient, and if a cylinder is left behind, the patient is not going to be satisfied. So keep your margin of shifting to toric IOL not very high. Don't do it for 0.5 or 0.75, but 1 and above, you can think about a toric IOL. It is not a requirement that you need an optical biometer to calculate the IOL power, but make sure that you're checking the keratometry using at least 2 or 3 instruments, confirm the axis, and then you can happily go ahead with your toric IOL case. Marking of a toric IOL is also very important. So you can either use a bubble marker preoperatively in correct position. Make sure that the other way of marking is on the slit lamp. This is where most of us find a little difficulty. You have to make the beam 0-180, then make sure that the head is properly aligned. So check in one eye whether it is dissecting the pupil, and then check in the other eye also whether it is dissecting the pupil or not. If let's say it is dissecting here and it is somewhere over here, that means that probably the head is tilted. So align the head as well before marking your cornea preoperatively. Ma'am, would you like to add anything to that?
Right. Yeah, these are very, very useful tips which you have given, Dr. Pavani. Also, I think you should take the help of the IOL manufacturers. They sometimes they will help you in giving the correct. So if you just manage to take a good K reading and axial length, and you can send them to across to the particular IOL which you are going to, especially for toric and trifocals. So sometimes these manufacturers will, calculate, and they will use these online calculators, and they will help you with the calculation. So they will give you a good value. And the other thing is that some of these IOLs, these formulas need the effective lens position. So for that, you need to use the optical biometer. But apart from that, a good trained operator with an ultrasound biometer and with access to immersion, somebody who can do immersion scan well, will serve the purpose. But increasingly these days, people have stopped using ultrasound biometers, so they are getting out of practice because it's so easy to use an optical biometer. It doesn't take any time.
Correct.
Okay, ma'am. Thank you, ma'am. Thank you.
So thank you everyone for attending, and thank you so much, Dr. Pavani. It was such a exhaustive, extensive, and well-researched talk, which I'm sure you must have worked very hard to come up with such a thorough understanding of this topic, and I'm sure it is going to benefit our students, our PG students a lot. And I think this is a very important topic for examination also. So for both your practical, your theory, and it's something which will always keep coming in handy for in your future as well when you come into practice. So thanks a lot, and we'll meet again next week. So this is just a word about the physical iFocus, which is going to be held from June 9th to 16th in Hyderabad. And we urge you to hurry up and register because the early bird registration will soon close. So this is an invite to all the PG students out there to hurry up and register for iFocus 2024. So with that, we come to the end of our session for today. Thank you, Dr. Pavani, for joining us.
Thank you,
Yeah.
ma'am, and thank you everybody for attending. And I hope it was useful to everybody. And yes, I also put on because of this, I also gained some knowledge. I'm happy to be a part of it. Thank
Yes,
you.
thank you so much. Thank you, Dr. Zishita and Dr. Tulika. And thank you, Sunil, for all the technical help. So then we'll meet again next week. Till then, wish you all a great week ahead and good night from us here.